Okay, hi everyone. This is Dr. Anokhi from the Apple Tree Pediatrics. This is the Health Scooter Series live chat. We're going to be discussing asthma with Dr. Richardson from Texas. Okay, hold on a second. I'm just waiting for her to come online. We're having a little bit of technical issues. Do apologize. Right. Let's see. You're still not coming on my... How do I add you in? Why are you not coming on my viewers? I'm inviting you in.
Good.
Perfect.
Perfect. We did it.
It worked.
Yes, it did. Very good.
Anyway, hi, Dr. Richardson. Okay.
Hello, how are you?
I'm
How are
good.
you?
How are you doing?
Good.
Once again,
doing fine.
Yeah. Thank you so much for agreeing to do this with us.
No, it's my pleasure. It's my pleasure.
Okay. So would you like to introduce yourself so our viewers can get a bit of an introduction?
Sure. Okay, I'm Carolyn Richardson, and I'm over here in the United States in the great state of Texas, and I've been a pediatrician for 30 years. It just so happened to where I trained, we had an allergy and asthma fellowship. So we saw a lot of patients with asthma, a lot of patients with allergies. And I have seen asthma go through many changes, and we have a lot of good medications now. And we also know what is asthma and what's not asthma, and we will be covering all of that today.
Excellent. That's really, really good. And I like the fact that you highlighted that it's gone through a lot of change.
Yes.
It's important that people understand medicine is not a static
Yes.
occupation. It's constantly changing.
Constantly
You're
changing.
having to go online, check your resources, constantly check. I've had one of my friends comment, "Oh, I thought this doctor was not very good." I was like, "Why?" They're like, "Oh, when I was asking them questions, they say 1 second and they actually researched it." And I was like, well, yes,
that's a good thing.
What you want them to do,
Right.
You want them to check to make sure, am I following the latest guidelines, especially if it's something weird and wonderful, which it often is. Anyway, before we jump right into the asthma, I thought we'd just touch up a little bit on our regular viral illnesses, like a regular cough and a cold. Winter month, winter seasons. So we're seeing a lot of it. We know the cold, dry environment makes it very conducive for viruses to spread. That's why we're seeing a lot more coughs and colds in this time of the year. So how many coughs and colds are normal? I mean, I usually say, even if your child comes down who's going to school pretty much every month with a runny nose and a cough, as long as they're growing, developing, and recovering well, is not uncommon in the smaller age groups.
Exactly.
Do you agree?
Yeah. Yes, exactly. So what about, that's what we tell the parents, like usually 7 to 9 colds in a season. So if it looks like, the child just got finished with a cold and now they have another cold, I always tell the parents, they're building their immune system. That's why you don't see school-age children in the waiting room. You only see small children in the waiting room because they're building their immune system. And as long as they're recovering and they're growing, like you say, growing well, eating well, you just treat their runny nose, give them a little tea with lemon or something like that, and they get all right. Yes.
Yeah. Coming to that. So what are what is your opinion on cough syrups?
Well, the thing is that especially under the age of 6, we do not recommend cough syrups. Number one, because they don't really work, and you don't want to be affecting the child's ability to breathe with cough syrups. So what you do is you just treat them to make them comfortable. Honey is very good. Lemon is very good. You can just warm it up with a little water and give it to the child. It's very good. If their nose is running, you just use like saline nose drops to just keep the airway open to keep them from being congested, make them comfortable, and they'll be fine. A lot of times if their throat is a little dry, they may cough from that. And if they drink something, then their throat won't be dry and that'll stop their coughing.
No, thank you. That's very good information. And it's important. So we're going to like, somebody's come online, Gansham Das. Hello, Gansham Das. So we're going to dive right into the asthma side of things. Not every cough is asthma, and not every cough requires, over
Asthma
here they use a lot of nebulization with steroids, a combination of steroids and Ventolin. And I'm like, first of all, we don't use that combination, number one. Number two, there's a lot of patients come in with the routine, okay, my child's been coughing for 3 days, so I've given them the beclomethasone combined with Ventolin. There's this nebule that is available in Pakistan, and like, it's not getting better. So I think it's important to highlight that every cough is not asthma.
That's right. That's very important. A lot, especially when they have a cold, they'll have a cough with a cold. And so most of the time, if you just give them something to soothe their throat, because it's kind of a nerve, it's kind of irritated. So that's why they keep coughing. So if they drink a little something to soothe that nerve, they will stop coughing. Yeah.
No. Okay. So to start with, what is asthma?
Well, asthma is a special respiratory reaction, basically, to some kind of trigger. You could have a cold and have like you could have a viral illness and that'll trigger it. But a lot of times it's things like pollen, things that float in the air, pollen, dust, animal dander, like a cat or a dog. Dust is everywhere, and that can be it. Like the little mites that live in the dust, that can trigger asthma. Strong fumes, like some people like to do a lot of air fresheners or have those odor infusers that put different strong odors in the air, and that can actually be an irritant to the airway. So anything that can trigger the airway, and if the airway is a little sensitive and then reacts to that, that's what asthma is. So if the tubes in the airway go into spasm, that's when you need medicine. If you don't have spasm going on in the airway of your lungs, then you don't need asthma medicine, even if you're coughing. Yes.
So what is the typical, or one of the typical histories, what you see? So when a child comes to you, what are the typical stories you hear where you start thinking that, you know, this may be asthma?
Could be asthma. Yeah, a lot of times what they'll be having is like difficulty breathing. They may even be wheezing, where you can hear this whistling kind of noise when they're breathing, especially when they breathe out. And the child will be having difficulty breathing. You may notice that the child may not be as active at play, or get tired when they're playing more quickly than their friends. And if it kind of, especially if it's around the time when there's a change in the season, or if the air temperature has gotten cold or something like that, those would be the things that make you think, maybe this is asthma. And especially if there's some kind of allergy history also, that makes you kind of wonder, is this asthma? I think this might be asthma. Yeah.
Yeah. And just to highlight that when we hear wheezing, it's because a lot of parents like, I don't hear anything. It's when we actually listen to the lungs.
With the stethoscope.
So,
yes.
With the stethoscope. Because then I would have parents coming in, I'm not hearing wheezing.
Right.
So when you're listening to the lungs with the stethoscope.
Right.
Yeah.
Exactly.
What about the prolonged cough? Regular nightly coughs, prolonged coughs that may not have the typical symptoms, because we sometimes see those, not so common, but we sometimes see those patients. Okay, they may not come in with the typical presentation, but they just have a cough that is never ending.
You can have a cough variant asthma, but again, these are children who are like coughing even in their coughing. So if they have like a bad or things like that, those are things that kind of make you think of asthma. If the cough has been hanging around, for more than a week, or usually if it's just a cold, the cough tends to start trying to taper off. But if the cough doesn't taper off and it just continues, and especially at night, or say like after the child runs and plays, they start coughing. Those are things that kind of make you think more of asthma. Yeah.
Yeah.
Like the child was fine until they were running and playing, and then they started coughing. Then that makes you think of cough variant asthma. Yeah. Or exercise-induced asthma.
Yeah. And just to highlight, not every night cough is asthma. because sometimes your regular runny nose cough can get worse at night. Everything gets worse at night.
Oh yeah.
Emergency rooms are always
when they're draining, when they lie down and the mucus is draining, they will cough. So yeah, that's true.
Yeah. So so going on from definition of asthma, what are the tests for asthma?
Well, there's no actual tests for asthma. Asthma is basically, it's kind of like you see a pattern of symptoms and you say, hey, you see this group of symptoms together, especially the difficulty breathing, the wheezing, the shortness of breath, or breathing fast, breathing hard. Those are the things that make you think of asthma. And then you check the chest. You may hear wheezing when you listen with your stethoscope. Those are the things that make you think of asthma. But there's no test. There's no, like, when you draw their blood and get a result and say, oh yeah, this is asthma. There's no test for that. You just look at a pattern of symptoms.
Yeah, no. And the spirometry, because I've had parents come in, oh, my child had a spirometry, which is your lung function you do on this machine in a lab, and they're like, it was normal, so my child doesn't have asthma. But when they come to me, they are having the symptoms of asthma.
Exactly.
So maybe we can touch upon that. Why was the lung function normal?
The spirometry normal? Well, see, the thing is, it just depends. The spirometry can be still in normal range because you have to lose more than 80% of the function of the lung before you start saying, oh, this is not normal. So you can have symptoms of asthma. You could listen and hear wheezing, and yet their spirometry would be still in the normal range. But you can still have symptoms even if the spirometry findings are normal. So they would still require treatment. They would still require treatment because they have the symptoms.
No, that's very, very, also for me, that's very, very good to know. Very interesting to hear. Sorry, I just need to log back into my computer. Got my questions up there. I do apologize. I'm trying to be green by not printing out. Okay. Let's go on to treatment and management. So what's the first line treatment of asthma?
Well, the first line treatment is the albuterol. I think you call it salbuterol.
Salbutamol, yeah. In Europe,
salbutamol,
and
yes,
in Pakistan, we call it salbutamol. Yeah.
But you want to keep
brand name Ventolin. Parents
yes,
understand
the Ventolin, yes. And I always tell the parents, keep all your medications separate. Don't combine. It's better not to use, especially for your quick reliever medicines, you want them to be separate. So I know they have a medication that's kind of combined with the steroid, but the problem with that is that the salbutamol is given like every 4 to 6 hours. And the recommendation for steroid is either once or twice a day. So if you're giving it more often than once or twice a day, that's too much. That's too much.
Yeah. So what is the salbutamol or the Ventolin doing when you give it to your child? And when do you use it?
The Ventolin will stop the spasm. The key thing that's going on is you have spasm in the little tubes of the lung, the airways in the lungs. So the Ventolin is calming that spasm down. It's causing the muscles that are around the little tubes and airways to relax and open back up. Because the reason why the child is struggling to breathe is because the airways are squeezing closed. So if the airways are squeezing closed, they breathe in the Ventolin, and that causes the muscles in these little tubes to relax and open back up. And now the air can flow freely, and the child no longer is struggling to breathe. And because there's no mucus leaking and there's no spasm, that also stops the wheezing. So it works, it's quickly working on those things that are causing the child to have difficulty breathing.
So when do we then start with steroids? Or would you like to talk about the leukotriene receptor inhibitors like Montelukast?
Okay.
Because I have questions about that.
Yeah, well, the recommendation from we go by the recommendation with NIH, and they have a step kind of therapy. And if you're using those the quick reliever medication like the Ventolin, and it's not, and the child it's like the child gets okay, and then they have to use it again. So we have kind of like a rule of 2. If they need that more than twice a week, then that's an indication that they need to use inhaled steroids. Inhaled steroids are a lot safer than drinking the steroids by mouth, like in a syrup, because when you drink it in a syrup, it's affecting the whole body, all the organs in the body. Whereas if you breathe it into the steroid into the airway, it's targeted right at where it needs to work. And so the steroids get in, they calm down the inflammation, and they make the airway less sensitive to the triggers that start the spasm in the first place, and they make the airway less reactive to triggers. And so all that helps control the symptoms. So that's why the inhaled steroids fall into the category of the controllers, because they're actually controlling symptoms and keeping you from having to need your quick relief. What guides needing the steroids is if you have frequent use of your quick reliever, the Ventolin, that's an indication that you now need to add an inhaled steroid.
All right, yeah. I have a parent asking a question, very valid question. What about prednisone?
We do, right in the first couple of days of an asthma attack, when the child is having a lot of difficulty breathing, we do use the prednisolone, the little syrup, or sometimes there's like a little dissolvable tablet. We do use that to also help open the airways and calm down the inflammation. But you can only use those medicines that you take by mouth safely for about 4 or 5 days. After that time, you need to transition to the inhaled steroids, because it's a much, much lower dose, and it's not affecting the entire body. It's only working targeted right at the airways. So that's why you want to switch from using the oral steroids, was like an emergency medicine just to kind of get everything under control, and then you switch over to the inhaled steroid.
Yeah. And I think it's important to highlight that your steroids take about 2-3 days to actually kick in. So they're not an emergency medication.
Right,
parents,
exactly.
well, they're like, it's not doing anything. I'm like, it is doing something. It's reducing the inflammation, reducing the reaction, and reducing the need for Ventolin. But Ventolin will always be your first line.
The first line, absolutely.
Yeah. Wanted to touch, do you use Montelukast at all?
Yes, Montelukast is, yes, Montelukast is important, especially if there's a strong allergy component. The way one allergist explained it is like the upper airway gets inflamed first, and then that inflammation passes down to the lower airway. So you start off with itchy eyes, runny nose, and like that, and then the upper airway is inflamed. That inflammation, if it's not controlled, will then pass on down to the lower airway. So, and I have seen that in patients that have strong allergy component, because a lot of times they have what we call they have allergy and they have asthma. And leukotriene is very effective. It's like an add-on medication, and it's very effective if you to help control the upper airway so the lower airway doesn't get inflamed. Yes.
Yeah. No, that's really, really good. Okay. So how often should we use, well, we've already touched on that, relievers in children, Ventolin, because I have a lot of parents who get really frightened.
Can be used.
Use Ventolin, it makes the heart rate goes up, and I'm scared of that.
Yes. Well, the increased heart rate is a brief thing, and as soon as they stop, as soon as the breathing treatment is over, their heart rate goes back to normal. Plus, the other thing I always tell parents is that, the child is terrified because they're struggling to breathe. That alone will cause their heart rate to increase also. So if you can get rid of the breathing difficulty, that will also help the heart rate come down.
Yeah. No, that's really good. And I've always seen, the kids tolerate the increased heart rate very well. They start breathing, and then they start jumping off the walls from being a very sort of irritated, sedate child who can't breathe, and then suddenly the lungs are open. They're like bouncing off the walls. They're all excited.
Yes, because they feel better.
Of course,
they feel better.
Yeah, and then obviously the heart rate goes up very nicely. Yeah. Okay.
Yeah.
So as a general rule, we don't. I don't recommend nebulizers at home. What is your opinion on that? Because over here, it's like. Inhalers are not used that much. Everybody has a nebulizer. And I'm just, in the UK, we've seen, research has shown that if you use the inhaler via spacer, not only is it more cost effective, easy to carry around, cleaner, but the side effects are less prominent. And there's a slight reduced need for admission in hospital if you're in inhalers rather than nebulizers at home. And then how are you supposed to use a nebulizer when you're outside?
Mm-hmm. Well, the other thing is that nebulizers a lot of times are more effective, especially when the child is very young. But once they're at school age, you're right. A spacer with a inhaler is effective, because the key is you need the spacer so that the medicine gets delivered to the airways. If you're just kind of squirting the inhaler in the child's mouth, they may be swallowing the medicine and it's not getting to the lungs. So you do need a spacer with a mask so that the medicine actually gets to the airways where it can be effective. Yes, absolutely.
And with the nebulizer, I just recently had a patient who's like, I took some normal saline and I was told to put 1 drop of Ventolin, which is less than 2.5 milligrams.
Yes.
So what can you tell us about that? The importance, the minimum dose that you need of Ventolin in the nebulizer for it to work. Otherwise, there's no really point in doing.
Yeah, yes, you especially if you have the unit doses that are already prepared, you have to use the entire dose to get the proper effect. If the child truly is wheezing, to give them saline that just has a drop of the Ventolin in it will not be enough medicine to get rid of the spasm and to get rid of the tightness in the airways. So they have to have the effective dose, the correct dose, the right dose, so that it will get rid of the spasm and get rid of and relax the muscles and open up the airways.
Yeah. Would you like to say something about peak flow meters and asthma action plan?
Yes. Peak flow meters are kind of give you an idea of how the child is doing. So like you see the child and they might kind of be not playing and not active and really quiet. You might want to check their peak flow meter to see what level they're at. And if the level is indicating that they need to use their reliever medicine, then you would want to use it. Yes.
Yeah. So just to explain to my our followers who are on right now, or the ones who will look at this afterwards when they wake up. So your a peak flow meter is a small little gadget. It's just a tube that your child blows into. So we usually ask them to do it 3 times and then take the highest measurement. It's just to see their lung function. It's a simple home gadget just to see the lung function. We tend to ask, in order to create your asthma action plan, we usually ask our patients to do it for 2 weeks in the morning and evening after brushing their teeth, so that we see where your lung function is. And then if you can just describe like how do we create an asthma action plan using the
the asthma action plan, say for instance the child has symptoms, they're not that frequent, so that child would not need a controller medicine, so they wouldn't have any medicine that they're taking on a daily basis. But if they reach the level where they need to use their rescue medication, then it gives them this is when you need to start the rescue medication. And then, of course, if the child is at a level where they need emergency attention, where they need to actually get in to see the medical provider or the doctor, then you do give them a reliever medicine at home, but then you get them to the doctor so that the doctor can then listen to their lungs with the stethoscope. Sometimes you can even assess their oxygen level, kind of see how difficult, how much struggling to breathe they're doing. All of these things would then guide what treatment they would need to get them back to normal. Yes.
Yeah. And just to explain to parents, an asthma action plan is actually a printed out sheet that we give that is basically tailored to the need of your child.
Your
so for
child,
each child,
specific. Exactly.
Individually tailored according to the medications they're taking. And it gives you a guide of, as you said, what to do in an emergency. And it's also very good to have a set of the asthma action plan as well as the Ventolin with spacer, set of fit line in the child's school with their school teacher for emergencies. Just an important thing to highlight for parents, unless you are living right next to a hospital, if your child is having a severe asthma attack with difficulty in breathing, it is still better to call an ambulance. We have so we do have problems with ambulances here, unfortunately, Dr. Richardson, but we do have there are several services. One that I've had personal good experience with is the Aman Foundation. They're all charity ambulances. The number is 1021. It's an emergency number, and the most important thing with an ambulance is that they have oxygen.
Yes.
And it's
Yes.
important
Yes.
that your child needs oxygen. So in
Yes.
case you get stuck in traffic, in case you are taking the time to get to the hospital,
Exactly.
you may think, oh, I can drive crazy and fast and get there faster.
No.
But
No.
that time is not enough. Your child will need oxygen. So even if you have to wait at home, Aman Foundation has been in my house like within 5 minutes when we required oxygen. So as long as they can get there quick and they have oxygen, they actually have it in the ambulance itself.
The ambulance.
They have a machine
Exactly.
that,
Exactly.
yeah. So, but not all of them. Only Dr. Aman Foundation I know has it. The the machine that actually makes the oxygen, so you don't need a canister separate.
Okay.
A lot of the other ambulances just have, if you're lucky, they'll just have a canister of oxygen there. Tanks, yeah.
Okay. Yeah. Okay.
So yeah, we're not as sophisticated as in Europe and the US with our ambulance services. But yeah, that's why people are not used to using it, and I'm trying to highlight the importance of it, is that it has oxygen, and just remember your child cannot breathe, and they do require that oxygen. Really important.
Yes. Yes. Especially the tighter their airways are closed, the more they need the oxygen. Absolutely. Yeah.
Really, really important. Just another few more questions. Antihistamines in asthma, what role do they play?
Well, antihistamines are not used for asthma. Antihistamines are for allergy, so they're not used for asthma at all. They don't impact the airways in the lungs, so they don't help with asthma. If you're having an asthma attack, antihistamines will not help you.
Yeah. So yeah, because I have a lot of parents coming, they're like, my child has an allergic cough, so I need to give them antihistamines.
Yes. No, antihistamines are for itchy eyes, runny nose. They're for allergy symptoms, but they will not help asthma. No.
That's your asthma. Yeah, no, very good. I don't know if we want to, this is a bit more in detail. If you're happy, we can discuss. But I had a parent message in last night, and she was wondering if you could touch upon the, this goes in a little bit more higher level, IgE and non-IgE linked.
The allergic?
Yeah.
The allergic asthma?
Which is allergic, yeah. So it's basically allergic and the non-allergic. So that's IgE.
Yeah. They have the allergic
asthma, which is very rare.
Their allergic asthma, number one, is very rare, and then they have their own specific medications for that is specifically for to treat allergic asthma, people that have high counts of eosinophils. Like, there's a specific class of medications for that. Yes.
Yeah. So, but kids that we see,
and you have to be careful with that, because those medications also have age restrictions. I mean, not restrictions, but they have recommended ages to use them for. Like, they have one that you can't use it under 12 years old, and they have another one that's only for 6. So you have to be very careful with those medications.
No, so but basically the run-of-the-mill asthma is not eosinophilic asthma. It's just to highlight to parents.
No,
it's the regular asthma. Even though a lot of people would say this is the allergic, this is the eosinophilic. It's not. Allergic is basically your eosinophilic asthma. It's very, very
that's rare.
Very difficult to treat. And just to highlight also, so I just read a study. It was done 2-3 years ago in Wales, I think, where they basically were checking who are the unfortunately who are the patients who are actually dying from asthma. And surprisingly, because basically they have the NHS, so the entire system is centralized, so they actually could check who the patients, how their asthma was classified, what were the medications. And the thing what they saw was they checked whether the prescriptions were being filled or not, whether the patients were actually going and taking the prescriptions or not. And one of the most interesting things is, we would assume it's one of those, the people dying from asthma would be the ones with really horrible, hard to treat asthma, which was not the case. It was the moderate cases of asthma, because and it usually happened in the late teens, because they, you got the ones who are entering early adulthood, because they couldn't understand that my steroid, my preventer, which I'm using as an inhaler, is actually making a difference, because you don't feel any difference, unlike when you're taking your Ventolin. I'm asthmatic myself, so when I take my Ventolin, I was like, oh, I can breathe, you know?
Right.
But when
Yeah.
you take a steroid, you don't really, you think, oh, it's not doing anything. It's not making a difference. I don't feel anything.
Mm-hmm.
But it's also important, I think, to highlight with Ventolin, the more you use it, that's why you need to
Yes.
come with steroids, your lungs get desensitized.
Yes. Well, not only that, when you're having to constantly use the reliever medications, that's also causing damage to the lungs. That's the other thing. You want to use the inhaled steroids to keep the inflammation at bay, to make the airway less sensitive, not so easy to be triggered and to going into these reactions. So the steroids are actually helpful in that regard. That's what guides when you need to know to use steroids. Is the person having to constantly use their reliever medication? You're supposed to use one inhaler should last you an entire year. People look shocked when I tell them that. If you're needing more than one inhaler for the entire year, you don't have good control. So the medication has to be adjusted to give you good control. And see, you're right. Even though you take the steroid and you don't feel some big sense of, but if you're the test that the steroid is working, and that you're not constantly reaching for your Ventolin. If you're constantly reaching for your Ventolin, then your asthma is not under control.
No, that's really good. I got Renara Buya writing in, allergic cough is self-diagnosed. Yes, that's true. A lot of parents come in, I think my child has allergies. I think my child has allergic cough. With allergies, every runny nose. It's a lot of my patients have been shocked to find out that their little ones are not allergic. And that they simply have a regular cough and cold that basically, and then they'll start noticing it's during the school year that they're constantly having it, and on vacation time there's nothing there.
Right,
So majority of the patients who come in do not have allergies. It's just your regular cough and cold.
Cold, yes.
So we've done the asthma action plan. We've done our relievers. We've done our preventers. God, there was another question. We've finished, gone through all the lists. Is there anything else you'd like to say about asthma?
Well, just to point out about children having frequent colds during the cold and flu season, a healthy child can have anywhere from 7 to 9 colds in a cold season. And if the cold takes about 7 days to get over, that's why it looks like every time you turn around, the child has another cold. But you have to understand the child is building their immune system. And when they're older, they won't get as many colds. So it's fine. And a good thing I always tell my parents is, if the child has a cold, especially if they have a little low-grade fever, change their toothbrush, because their toothbrush can be a source of where the virus, they can reinfect themselves with the virus. So change your toothbrush. That helps a lot.
Oh, very, very good advice. Very good advice. No. Flu vaccine. That was the question. I couldn't remember.
Ah, yes. Yes. The flu vaccine is recommended for any child, well, for all children 6 months and older. And if the child has any kind of respiratory issues, they definitely should get a flu vaccine. That's just required. Of course, the first time they get it, and if they're under 9 years of age, if they're from 6 months to 8 years old, that's the very first time they get it, you have to get a booster in a month. But then after that, you just every fall season, and it's good to get it early in the season because it takes about 2 weeks for the protection to get on board. So you want to take it early in the season, like, this is the time you want to get it, because once the winter hits, you're into late October, early November, that's when you really want to already have your flu immunization protection on board. Yes.
Yeah. And just to highlight, the flu is not that common runny nose and a cough you have.
No. Flu is high fever, achy joints, flu, you can tell flu is different from a cold. A cold, your nose is running, you're coughing, you're still running around, everything like that. When you have influenza, we're talking high fever, just throat may be really burning and sore. You have achy joints. I mean, you're like really sick. So flu is different from that, and you can do a test for the flu, and you can take flu medication for that to get rid of it. Yeah. And again, if you have the flu, change your toothbrush.
Yeah. Unfortunately, just to highlight, in Pakistan, we do not have the rapid influenza, rapid flu kit. We don't have it here.
Okay.
I did
but you
look
can
into
look,
it.
a lot of
It's
times
like,
you look at the child, you can tell they have the flu. You
yeah,
just look at them.
yeah.
You can say,
And
yes, this is the
once you
flu.
send to the lab, by the time you get the results, there's no
Oh
point
yeah,
because you need
they're
to treat
better,
the influenza
right?
within 24 hours.
Yes.
So with the antivirals, and just to
Yes.
highlight, okay, what role do antibiotics play in the flu?
Well, to see, the flu is a viral illness. So
Yeah.
you don't use antibiotics for bacteria. So you don't use antibiotics for the flu. You don't.
Yeah.
If somebody has a viral illness, then they need an antiviral, which is what the flu medicine is. Yes.
Yeah, yeah. And you have to give it within a certain period of time. Otherwise,
Yeah, you try to catch it within the first 48 hours of the symptoms.
yeah.
Yes.
Yeah. Otherwise, unless it's something severe, there's a big question about whether it makes a difference to treat it beyond that, because it's not going to make much of a difference. But yeah, unfortunately, we do not have the rapid flu test here. We do carry the rapid strep test in my clinic for the streptococcal throat, so that we can differentiate between viral and bacterial throat infections.
Yes.
But unfortunately, not the rapid flu. All right. So, follow-ups. Sorry.
Now it's good. It's good to follow up. It's good to follow up. Most of the time, it's good to. They usually see them like every 3 months or so. Depending on how severe their asthma is, will kind of guide the follow up. So if the child is, not having too much, it can be seen like every 3 to 4 months. But if the child is needing to have their medication kind of adjusted, you're trying to get them under control, they might have to initially be seen like every 2 or 3 weeks until you can get them on a regimen that keeps their symptoms under control. So it just, how severe their asthma is kind of guides how often they need to follow up. So the more frequently they're using their Ventolin, the more often they need rescue treatment, then we need to tailor their treatment and their controller medicine. So that would require more frequent follow-up. Yes.
And I also explain to parents, it's also a good way to always reevaluate, does my child still need the steroid? Does my child still need the steroid? Can I go down on the dose? When can I come off the steroid? Would you like to just highlight a bit about that, coming off medication as a child grows? Because some of them do sometimes grow off it.
Yeah. Well, the thing is, as a child grows, they may be less sensitive to the things that trigger their asthma in the first place. So they may have less problems. And so but you never kind of outgrow it. You may be less sensitive to things that trigger, but you always have to keep it in the back of your mind. I remember clearly this little girl hadn't had an asthma attack in about 2 years, but she went on a hayride with her school trip. And the hay was a trigger that sent her into an asthma attack. And the mom initially didn't realize what was going on because the child had been fine for about 2 years. And then, but knowing that she had that history was what guided the treatment. And hey, something. And then, of course, when you check her, she's wheezing. And I explained to mom, I said, it was that hayride that did it. Another thing, teenagers, they've been doing fine. They go on a camping trip. And next thing you know, they're having chest tightness. They don't know what's going on. It's your asthma. So you have to always keep that in the back of your mind. If they had asthma and if they've been fine for a while, but they start having the symptoms, always keep that in the back of your mind. Something, I think this is another flare up. Yeah.
So before we finish, I just wanted to highlight the difference between a viral induced wheeze, so the wheezing episode in the younger kids, and asthma in the older kids.
Okay.
Because you have a large percentage of small kids who can become wheezers, but it's based on their anatomy more than anything else. So would you like to?
Yeah, some children, some infants, you do see wheezing in infants sometimes if they have a viral illness, but that doesn't mean that in the future they'll develop asthma or anything like that. So there are other things that can cause you to wheeze, and it doesn't always indicate that they have asthma. So yes, viral illness can cause wheezing. Yes.
Yeah, in small children, and we usually say
in infants. You usually see that usually under like 2 or 3 years old. You see that.
Yeah.
And, but then there's a cell line that kind of switches over, and then once that gets turned on, they don't do that anymore. Yeah.
Okay. So we have a question come in. My son also never had asthma. He's 2 years old, but this is, sorry.
The weather changed? And she noticed?
It's 1 second. I got to open it up on my Facebook
Yeah,
because I can't see the rest of the question.
Yeah.
I'm sorry, Asthma. I can't see the rest of the question. I noticed his breathing. What with the weather change? Can you write that again? The second bit.
Can you tap see more to see if that opens it?
It's not. Can you tap see more? Because with me it's not opening.
Oh, I don't know. Want me to try?
Yeah, just try and see. Are you seeing the whole question?
Well, it went up now. It's not there anymore. But I saw see more was in blue letters, so I wonder if I tapped that.
Yeah, I know. With me, it just keeps coming up to what you call abdomen or something.
She said his breathing pattern changed. His breathing pattern changed. Yes. Well, that's when you would want to bring him in, because it would take the doctor listening to his lungs to see if wheezing is there. If he's wheezing and retracting or something like that, then that might be a sign that he would need treatment. Yeah. So he would have to be seen.
Yeah. So the mother's saying it was viral. Well, as Dr. Richardson has highlighted, viruses can trigger wheezing episodes. In the very small kids, it's just because of their anatomy. In the older kids, it can be very likely due to asthma. So viruses, infections are a trigger for asthma.
Yes.
For having an asthma reaction. They don't give you asthma, but they can trigger your
they can trigger the spasm in the lungs. The spasm.
Does he need follow-ups? So I
would say yes. I would say yes because you have to see what pattern is he. If he develops a pattern where he has recurrent episodes of wheezing, then that would be something that would need to be addressed. But if it's just kind of one-time thing, then that would be fine. Yeah.
Okay. Steroid nose spray in asthma?
No, steroid nose spray is not for asthma. Steroid nose spray is for allergy. It's for people that have bad allergies, a lot of sneezing, itchy, watery eyes, itchy ears, itchy throat. That's what and see, a lot of times you can use the nasal spray. Now that's when you would want to use like nasal spray along with something like either the Zyrtec or the Claritin or the cetirizine. And sometimes you need all three, depending on how severe the allergy symptoms are. You may even need to use Montelukast and nasal steroid. But this is all for upper airway. It's treating upper airway, not lower airway. Nasal steroids don't do anything for asthma.
No, very good. And decongestant, nasal decongestant sprays.
Now you have to be very careful with nasal decongestant sprays, because what happens is the body gets used to it, and then you have to use higher and higher and higher doses trying to get relief. It's better to use the nasal steroid for the swelling, because when you use the decongestant sprays, that's very dangerous, and it's not recommended to do that, especially in children.
No, I've just had I've had several cases where the kids come in with like really bad decongestant. It's merely because and the parents like, no, but we use it and then we take a break, and then we use it and then we take a break. I was like, you just don't use it, because they basically have the experience that when they use it the first time, they're like, oh, the nose clears up, my child can breathe. I was like, yeah, it works, but it has risk factors that are just not worth the benefit that you're seeing.
You have to use a higher and higher dose. It's better to use the nasal steroids for the nasal congestion. We have a question here about
the mom was asking about nebulizing with normal saline and Ventolin drops. So I personally don't use it. I use inhalers, Asthma. I use inhalers with a spacer, because you can dose them nicely. Always use your inhaler with your spacer. Again, with the drops, how accurate is your dose? I don't know. Nebulizing with Ventolin, you have to have a minimum dose of 2.5 milligrams in your nebule in order to be effective. If you go lower than that, you're just doing water. So, just a simple normal saline nebulizer with nothing in it is just nebulizing your child with water. It's not going to do anything.
Especially if they're wheezing or in spasm, it will not help them.
No. Again, I've had parents coming in who don't want to do anything, and they just want to do saline nebulization for a child with asthma. And I've tried to explain it to them that it's just not going to do anything. Your Clenil, I do understand that, so as Dr. Richardson had explained earlier, your steroid, the Clenil is a steroid, not the Clenil compositum. Clenil compositum is your steroid combined with Ventolin. That is not recommended because your Ventolin, as Dr. Richardson explained, you may need it every 4 to 6 hours, but the Clenil, which is your steroid, if needed, is only required once or maybe twice a day.
Right.
Flixotide, Evohaler, is that your inhaler? That sometimes we do. That's that I think is the fluticasone inhaler. That again is your steroid inhaler.
Yeah.
And yes.
But again, that's only twice a day. That's twice a day. That's a control.
That's twice a day.
Right. That's twice a day, morning and night.
Yeah, that's control. It. Yeah. She's like, she's been told by her physician to give it if she's concerned that he's catching a cold. We do, yes, in London. I don't know how you do that in the US. In the UK, kids who sometimes, if they have what we call is the viral induced, the virus is the trigger. We have sometimes, as soon as a child starts with a cold, we ask them to go on the steroid in order to hope that we don't require the Ventolin, because then throughout the rest of the time, they don't need anything, because if they don't have a cold, they are fine. They don't need the Ventolin. But in the winter months, when we're having more frequent coughs and colds, and if we're seeing that we're having more frequent coughs and colds, then the next step is to go through the entire season if the virus is the reason that is triggering your
the cough is
asthma. Yeah. But obviously the cough needs to be diagnosed as asthma. This needs to be a wheeze. This needs to be a reversible airway obstruction before we use any of this. Yeah, because I've had lots of kids come in who have the parents thought my child was asthmatic, has been nebulized with this combination. It's called Clenil compositum nebulization with the combination of dexamethasone and albuterol, which is a steroid, and Ventolin, and beta-mimetic. And they've literally done it every month, and I've stopped it all. And I'm just like, and they're like shocked that their child has nothing, not even allergies. They're like antihistamine, and I was like, no, your child has a viral runny nose. So it's just important for parents to educate yourself, understand the medications, understand what you're giving your child, understand that if your child does have asthma, does have reversible airway disease, you do need regular follow-ups and checkups, especially if they are requiring the Ventolin or your blue inhaler.
A lot.
Okay.
Yes.
Yeah. And really important is your flu vaccine. One of the questions that I get are, oh, I took the flu vaccine and then I got sick straight after that. So
well, my response to parents is that it doesn't work that fast. It takes 2 weeks to get on board. So if you got the flu immunization and the next morning you got sick, you're going to get sick anyway. And I've also had parents who have turned down the flu immunization and their children get very ill and they come back and, oh, I should have gotten the flu immunization. So it's not the immunization that made them sick. It's just that 2 things happen. One thing followed the other, but one didn't cause the other.
Exactly. Yeah, we call it apples and pears. So basically it's not the same thing. You were about to come down with a cold, and it's just you got vaccinated at the same time, and then your symptoms appeared. And symptoms can appear suddenly. Your runny nose and your cough suddenly appear suddenly. As a lot of parents are very surprised by that. They come running and my child suddenly started coughing. I'm like, yeah, that's how your coughs and colds go about it. Hydration and rest is really important. Avoidance of your allergies and your triggers really important. Identifying them is really important. Is there anything? So I think we've taken up enough of your time, Dr. Richardson.
Oh no,
is there anything that was really, really nice? Is there anything you'd like to say while we wrap up?
Well, that's the thing I would really like to stress is to make sure that if people are aware of their child's triggers, that they know if their child has been exposed to that, and then they start having symptoms, to put the 2 together and say, you know something, I think there's a flare up here. I think this could be an asthma attack coming on. And that's when they really need their medication. So if you know their triggers, then you know what to avoid. Like, you don't, if the child gets triggered by cats, then you don't want to go over somebody's house that has 3 cats, because then you know the child will end up having problems, breathing problems. So, knowing the triggers is very helpful in terms of keeping the child healthy. Yes.
And just before we finish, I completely forgot. What's the next step? Because over here, another thing I've seen is that instead of steroids, a lot of children are coming in with the Seretide inhaler, and that's what one of the parents asked me yesterday. As the next step, they're having a wheezing episode, and they put directly Seretide is your steroid.
No, that's a long. Is that a long-acting beta agonist?
Yes.
Yes. No, that the recommendation is that if they need a controlled medicine, inhaled corticosteroids is the first one. Sometimes they have steroids that are combined with the long-acting beta agonist, but you don't.
That's the
next step. That's not the next step.
But that's not but that's like after the steroids and things are just not improving, etc.
Right.
But it's not your first step. It doesn't matter how severe your attack is. It's not your first step. Your first step is always an inhaled steroid.
Yeah. We have a question from somebody said 30-month-old child.
Yeah, who's 2.5-year-old. He's been coughing for a week now. Do not give him any cough syrups. We've discussed this at the beginning.
Yes, under 6 years old, no cough syrup. You can use warm water with lemon, and since he's over a year old, you can put honey in it. That really soothes their cough. They also have homeopathic cough medicines. I don't know if you have that over there. There's a homeopathic cough medicine.
We don't. I don't usually recommend. Yeah, no, I just don't usually recommend.
But that is honey. It's honey based. It's honey based.
Yeah. No. Yeah. So over here we have our local homeopathic medications, and some of them have been tested, and they've had high dose steroids in it. So, Yeah. So these are not the same that you'd get over there.
No.
So I usually just recommend. Yeah. So it's not the same. So
lemon and honey with water.
Yeah. So I was like, you don't even need to buy these things. You can do it at home. Again, it's something that shocks a lot of parents. That I was like, you need to if it's not a wheeze, if it's not an asthma, you need to let it run its course. Most cases, it's viral. It can give fever. It can give high fever sometimes, and basically you just need to let it run its course. So don't do the homeopathic medication. I don't think
because they're not the same. They're not the same as the ones we have in the United States. It's not the same.
No. So just take honey. That is, the raw honey will be better, and you'll be safer with that rather than these medications. And be careful of all the locally mixed up medications, because there's no regulation.
There's no standard. Yes.
So we've got nearly 800 different pharmaceutical companies, out of which 700, that's what has been explained to me, have a big question mark on them. So gotta be very careful with the medications if they're not your regular school medications. And even between the brands, the massive quality difference. So I don't support brands. I just write generics. That's also a very UK thing, European thing, that we work with generics. We don't work with what you call.
Okay, this lady is saying she visits the U.S. frequently, so she can get it. It's called Chestal, Chestal, and there's no steroid or anything in it. It's just a honey based. Yeah, it's called Chestal, Chestal. Yeah.
Okay, that's fine. Yeah. Anyway, Dr. Richardson, it was really nice having you on.
Thank you.
Thank you really so much.
You're welcome.
I will, this will be shared again, and we will, yes, Chestal, that's right, C-H-E. Yes, that's the correct spelling. That's the correct spelling. Yeah. So I hope that the parents, when they wake up and they watch this, they'll find it very, very informative.
I think they will.
Thank you very much for your time. We're trying to, at the Apple Tree, we're trying to, educate parents. For us, education is extremely important to show it's the child's best interest in heart, and we want to make sure we're using the latest research and the latest evidence to treat your child. And modern medicine is all about limiting the medications and not using medications that don't work. Okay. Yes, honey and water, that's fine. Raw honey is your organic honey, Madiha. That's fine. You want it better than the factory honey, because the factory honey is just full of syrup. Okay. So I will say thank you. Good night, because it's late at night there right now. Okay.
It's okay.
I'll let my sister give you some nice cup of tea or something.
Okay. All right. Thank you.
Okay. Thank you so much. Bye.